Today, we're looking at something you've definitely seen hanging on a light board in a hospital right now.
Right, a chest x-ray.
Yeah, exactly. To most of us, it's just this blurry Rorschach test of ribs and gray blobs.
It really is, but for a doctor, that gray blob is literally a life-saving map.
So we're unpacking a lecture by Dr. Chirag Madan from Intellect Medicos today.
And his entire goal is to stop you from just seeing shadows and start seeing the actual story.
Right. And we actually want to give you the whole topic in about 1 minute, like a rapid fire cheat sheet.
Challenge accepted. Basically, you need two mental frameworks to avoid misdiagnosing a patient.
Okay, what are they?
First, you check the image quality with the RIPE framework. RIPE.
RIPE, got it. And the second?
Second, you interpret the anatomy with ABCDE. RIPE makes sure the image isn't lying to you, and the alphabet makes sure you don't miss the pathology.
So if you skip RIPE, the rest doesn't even matter.
Exactly.
Let's start with that quality control check then. R is for rotation. This feels like basic geometry, right? Like, is the patient twisting?
Yeah, you just look at the clavicles, the collarbones, and the spinous processes.
Those little bony bumps down the center of your spine?
Right, those bumps should be perfectly centered between the collarbones.
Like a target.
Exactly. If the patient is rotated even little, the heart casts a totally distorted shadow.
Oh, so you might diagnose an enlarged heart or a shifted windpipe just because their shoulder was turned?
You could, which flows right into eye for inspiration. Dr. Madan makes a big deal about counting ribs here.
Why is counting ribs so important?
Because x-rays require a really deep breath. You need to see about 5 or 6 anterior ribs above the diaphragm.
Anterior meaning the front part of the ribs.
Yeah, the front. If the patient breathes out, the lungs deflate and the blood vessels get all crowded together.
And crowded vessels look white on the film.
Which looks exactly like pneumonia. We call it an expiratory film artifact.
Wow, so you really don't want to put someone on antibiotics for a lung infection that's actually just them breathing out.
Definitely not.
Okay, so then we have the trickiest one. P for projection. This is the AP versus PA trap. It's essentially an optical illusion, right?
It is. Think of shadow puppets.
Okay, shadow puppets.
If your hand is close to the wall, the shadow is crisp and accurate. That's a PA view, which is the standard.
PA meaning the beam hits your back.
Right, the beam hits your back and your heart is close to the film at the front.
But in the ICU, patients often can't stand up for that.
So the beam comes from the front. That's AP. Now the heart is farther away from the detector behind their back.
Like moving your hand toward the flashlight?
The shadow gets massive.
So an enlarged heart on an ICU film might just be physics, not heart failure.
Precisely. Never panic about heart size on a bedside monitor.
Good to know. And finally, E is for exposure.
Just checking that you can faintly see the spine through the heart shadow.
Okay, so if the image is RIPE, then and only then do we interpret the anatomy with ABCDE. Let's hit A for airway. We're looking at the trachea.
We're looking for a shift. Dr. Madan uses this great push versus pull mechanic.
How does that work?
If you have something taking up space in the chest, like fluid or high pressure air, it pushes the trachea away to the healthy side.
But what if the lung collapses?
That creates a vacuum. It actually pulls the trachea toward the injury.
So the windpipe basically points a finger at the problem.
It really does. Which brings us to B for breathing and bones.
The rule of thumb here is simple, right? Air is black and bad stuff is white.
Generally, yes. Dr. Madan highlights some classic visuals. For example, if you see white fluid spreading out from the center of the lungs, resembling wings.
Oh, the bad swing 5.
Classic pulmonary edema or heart failure.
Got it.
On the flip side, if you see a section that is jet black with absolutely no white lines for blood vessels.
That's a pneumothorax.
Right, air has escaped the lung and is crushing it. And while you're scanning the lungs, you also check the bones.
Just tracing the ribs for fractures.
Exactly.
C is cardiac. We mentioned the size illusion earlier, but is there a hard rule for when the heart is actually too big?
The 50% rule. On a standard PA film, the heart width shouldn't be more than half the width of the chest.
And if it is, you worry about heart failure.
Yes.
Moving to D for diaphragm. This sounded like the scariest red flag in the entire lecture.
It is. You expect the diaphragm to be a smooth dome.
Right.
But if you see a thin crescent of black air underneath the diaphragm on the right side,
that means air is in the belly, not the lung.
It means the bowel has perforated. There is a hole in the stomach or intestine leaking air into the abdomen.
That is an immediate surgical emergency.
Absolutely.
Finally, E for everything else.
This is the man-made check. Pacemakers, tubes, wires, just ensuring the medical hardware is in the right place.
It's fascinating because it reinforces that an X-ray is just a 2D shadow of a 3D reality.
That is the big takeaway here. The x-ray shows you the what? The white spot or the deviated trachea.
But the patient's history explains the why.
Never treat the picture, treat the person.
That is great advice. But it does leave me with